When blood flow to the brain stops, the damage is immediately chemical. Within seconds of oxygen deprivation, the synaptic cleft floods with an uncontrolled release of glutamate, pulling a massive, toxic wave of calcium ions into the postsynaptic neuron. Without oxygen, the cell cannot produce ATP. The sodium-potassium pumps fail, causing catastrophic cellular depolarization. Historically, clinical models treated this event as a period of rapid tissue loss followed by a permanent, unchangeable plateau. But the biomolecular reality requires a different approach. Effective intervention must adapt chronologically, targeting immediate cell death on day 1 and combating structural network decay months later. The first requirement is immediate neuroprotection. In the first 7 days, the sole biological priority is halting acute excitotoxicity and saving the cells surrounding the main injury. The second requirement arrives around month 3. At this stage, the priority shifts to neurorestoration, forcing the brain to sprout new dendrites and forge alternative neural connections. This sequence is targeted by ACE-picocerebro, an advanced peptide formulation designed to address these shifting cellular crises as they occur in real time. Low molecular weight organotropic peptides cross the blood-brain barrier to initiate specific signaling pathways, permeabilizing the microenvironment according to the brain's current physiological stage. Post-stroke pathology is a continuous chronological cascade. To change the clinical outcome, the biological state of the tissue must be addressed with exact temporal-specific peptide interventions. Let's track this intervention starting at day 1. The initial focus is the ischemic penumbra, the highly unstable tissue immediately surrounding the dead core. This area is damaged but highly salvageable. Inside these cells, the unchecked calcium influx forces the mitochondrial permeability transition pore to open. Once that pore opens, pro-apoptotic factors like cytochrome C spill into the cytosol, initiating a programmed cell death sequence driven by destructive enzymes called caspases. This graphic illustrates the phase 1 acute window. Notice how specific neurotrophic analogs from the ACE-picocerebro formula, specifically BDNF and CNTF mimetics, enter this chaotic environment to stabilize the cell. These peptide fragments bind precisely to TRKB tyrosine kinase receptors on the surface of those damaged, salvageable neurons. That binding action triggers critical pro-survival signaling cascades inside the cell, specifically activating the PI3K-AKT pathway. Driven by this survival signal, the cell actively suppresses caspase 3 activation, shutting down the apoptosis cascade before the neuron destroys itself. By deploying targeted neurotrophic analogs in this exact timeframe, the localized tissue stress drops. The central nervous system preserves salvageable gray matter, stabilizing immediate neurological deficits before necrosis sets in. Moving forward to weeks 2 through 4, the biological threat profile changes. Acute cell death slows down, and the brain enters a chronic state of neuroinflammation. This phase is volatile. Microglial cells work to clear away the dead cellular debris, but their prolonged inflammatory state inadvertently damages adjacent surviving neural pathways. At this milestone, the therapeutic requirement pivots. The tissue now demands enhanced cerebral microcirculation and strict regulation of the glial immune response. Here, in the phase 2 subacute window, endogenous neuroprotective peptides derived from glial precursors interact directly with local astrocytes. They force these cells to transition from a destructive, pro-inflammatory state to a restorative one. Concurrently, neuropeptide Y mimetics are introduced into the recovering microenvironment. These NPY fragments act directly on the local vasculature. They trigger necessary vasodilation, ensuring that oxygen and nutrient delivery to the recovering neural circuits is fully optimized. Because the local immune response is contained and metabolic strain is reduced through better blood flow, patients typically display initial cognitive clarity and a marked reduction in systemic brain fatigue. By months 1 through 3, the brain's baseline rate of spontaneous neurological recovery drops near 0. This diagram isolates the primary structural hurdle during this period. A dense glial scar, composed of reactive astrocytes, has formed, physically and chemically walling off the damaged zone. This barrier actively emits chemical inhibitory signals that halt natural axonal sprouting. Meanwhile, the surviving neural pathways that used to connect to the dead zone face a secondary crisis. Stripped of their normal signals, they undergo rapid synaptic pruning and atrophy due to prolonged disuse. This is where the formula's therapeutic action shifts to active neurorestoration. Synaptogenic peptides enter these atrophied, metabolically depressed networks. Bombarded by these growth mediators, neurons initiate dendritic branching, pushing past inhibitory scar signals to route entirely new pathways around the dead tissue. Simultaneously, mitochondrial support peptides stabilize the inner mitochondrial membrane, restoring ATP production to power these newly expanding networks. When you structurally bypass the glial scar through induced synaptogenesis, stagnant neural connections awaken. This specific mechanism allows patients to break through persistent physical and speech therapy plateaus. Moving into month 4 and beyond, the patient enters the chronic stroke phase. At this late stage, the objective is no longer sprouting new connections. The priority is strictly protecting the fragile alternative neural circuits that have just been formed. As detailed in the month 4 to 6 panel, continuous organotropic peptide complexes are deployed to maintain a highly active, youthful cellular environment surrounding these structures. By sustaining this enriched microenvironment, these alternative pathways are protected against premature synaptic pruning. This constant chemical reinforcement stabilizes the structural durability of the new motor and cognitive gains achieved over the previous months. Securing these pathways guarantees long-term neuroresilience. The chronic metabolic fatigue cycle breaks, and late-stage functional decline is actively prevented. Zooming out from the cellular level, the full logic of the treatment protocol comes into view. This summary matrix maps biomolecular pathology to clinical outcomes from day 1 to month 6. Acutely, caspase suppression ensures infarct stabilization. Subacutely, managing glial signals reduces brain fatigue. By the chronic phase, induced synaptogenesis generates physical rehabilitation progress, while organotropic maintenance locks in neuroresilience. The entire strategy hinges on adaptation. You cannot use the same mechanism for 6 months. First, you must rapidly dampen the pro-apoptotic cascade inside dying cells, and then, months after the initial insult, you must shift entirely to actively driving structural rewiring and organotropic consolidation. Relying on a static intervention strategy while the biological timeline naturally evolves traps patients in the permanent clinical plateau seen in traditional recovery models. True recovery demands exact molecular precision. Specific low molecular weight peptides must cross the blood-brain barrier at the exact moment to serve as localized growth mediators. Aligning targeted peptide supplementation with the natural chronological pathology of a stroke enables the deliberate engineering of permanent functional neurorestoration.